Good evening. Welcome to UPMC Sports Surgery Clinic's public talk. And tonight we're talking on hip and knee replacement. Any of you that don't know us, we're Sports Surgery Clinic in Santry. We're 10 minutes from Dublin Airport and just off the M50 and the M1. We're Ireland's leading private orthopaedic hospital, so we probably do a large amount of joint replacements, probably more the most in the country. And we are a centre of excellence for joint and hip and knee replacements. Not just that, but we also look after the spine, your shoulders, wrists, hands, feet, knees, soft tissue like ACL. So they're the other things. But tonight we're going to concentrate on the knee and hip replacement. So we have over 40 orthopaedic consultants here with a team of very specialised and highly trained physiotherapists, strength and conditioning coaches and nurses, all trained in musculoskeletal work. 3 MRIs and 83 beds plus 18 day beds. If you want to know any more about us or you want to get in touch with us, there is a tab there at the end that says ask a question. And also to make an appointment further on. Now, tonight we have 2 speakers. Both of them will join us live for a Q&A. So that is another tab there for that ask a question. So please type in your questions. We will endeavour to answer them all. Some of them will be similar, so we'll group them together. And we will then, if there's some that come in afterwards, we'll try and email you back with an answer as well. So our first speaker tonight is Professor Brian Devitt, and Brian is going to talk about osteoarthritis and the knee, and then Brian will join us afterwards. Thank you.
Good evening. My name is Brian Devitt. I'm going to speak to you about knee osteoarthritis, what you need to know. So I always like using a picture of a patient with their consent, of course, and this is a lady who I performed a knee replacement on in Australia. And this is 18 months following her knee replacement. We went on a charity walk to Vietnam, and she was able to manage the steep inclines with her new knee, and she was very happy, as you can see on her face. So this is one of the successful patients we've performed a knee replacement on, and the vast majority of people do very well following knee replacement. But when we were in Vietnam, we also came across a number of quotes from Confucius, who is a philosopher, a Chinese philosopher, and this is one of my favorites. It doesn't matter how slow you go as long as you do not stop. And I think it's particularly relevant for dealing with knee osteoarthritis. And I'll talk to you a bit further about that during this talk. So my children always say to me, these are my 3 children. He said, Dad, tell me something I don't know. So the purpose of this lecture is to try to inform you about issues of osteoarthritis. So initially, we're going to talk about the basics. What is osteoarthritis and what treatments work? We also want to talk about the evolution of surgery, which is quite interesting. And what does the future hold for the treatment of osteoarthritis? So most people say osteoarthritis asks just a bit of wear and tear, and it can be just a bit of wear and tear, but it also can be an awful lot worse. Try telling this patient with this right knee that this is just a bit of wear and tear. And this is severe arthritis with lots of bony debris within the knee. But interestingly, the patient was presenting with his left knee as being the sore knee. So you just be amazed what people can put up with during their lives. So people come in all shapes and sizes. And when we see people with osteoarthritis, we see 3 main varieties of the appearance of someone's legs. First is a normal variety, which is just the straight legs. You see someone with a bow leg deformity, or what we describe as varus, or also people with knock knees, or what we describe as valgus. So these all have different patterns of wear, and that's for us to know as surgeons. And you can often distinguish where the arthritis is going to be based on the shape of a patient's legs. So what treatment works? So when I was going through my leaving cert, we had to do Macbeth. And Macbeth, there's this great line when the witches are around their cauldron. They talk about eye of newt, toe of frog, wool of bat and tongue of dog, adder's fork and blind worm's sting, lizard's leg and howlet's wing, for a charm of powerful trouble like a hell broth boil and bubble. Well, none of these treatments work for arthritis, unfortunately. And we get told an awful lot of things from patients as, oh, I might try this oil or this treatment. And we have to be very careful as to what treatment we advise people on, because we want to do recommend treatment that works for patients. I often get asked, should I use turmeric? And I don't really know. The only thing I realize about turmeric is you shouldn't get on a white shirt because it stains. So we really need to be very careful about what we recommend. So there's been a lot of studies on this, and we've looked at the various conservative treatments and what work. So physical activity, that is very important. Just like Confucius says, you don't want to slow down or you'll stop. So it's really important to maintain your physical activity. We know that weight loss is probably the most effective means of reducing the pain from arthritis. And I'll discuss this a little later. Acupuncture hasn't been shown to be very effective. Massage can be somewhat effective, as we can massage the muscles which might be a bit tight above or below the knee, which can cause pain. Braces can be sometimes effective, normally in early arthritis. Insoles, likewise, can sometimes offload the side of the knee that can cause trouble. Glucosamine, based on these studies, have said it's not effective, but glucosamine is a very inexpensive medication, and even if it has a placebo effect, it may help someone. I'm just going to bring you back to a little bit of physics, and this is Isaac Newton sitting under that infamous tree in Cambridge when the apple fell on his head. And one of the things we recognize about the treatment of arthritis is the effect of weight loss. So if we take an example, we'll do a bit of maths here. If you're walking, just normal walking, twice your body weight goes through your knee at each step. So if you're walking downhill, up to 4 times your body weight goes through your knee. And if you're running, 8 times your body weight goes through your knee. So if we do a little bit of calculation, if you take a 100 kilogram male, so maybe a male is slightly overweight, 400 kilograms is going through that person's knee walking downhill. If you're considering they're running, that's 800 kilograms. That's just shy of a ton going through the knee when they're running. So for that person to lose 10 kilos, it's 10% less of the body weight going through the knee and 40 kilograms less per knee per step going downhill. So you can see how effective losing weight is. So it's really important to remember that. We also recognize that exercise is important, and we recognize that trying to do exercise that doesn't exacerbate your knee pain is really critical in the early period. So the likes of Pilates is good, or low load exercise like cycling or swimming can be very, very effective to reduce improve the strength of your leg, but also to reduce the pain within your leg. So we really promote that. In terms of pharmacological treatment then, anti-inflammatory medication is effective. And the reason it's effective is that it reduces the swelling within the knee. When you have swelling within your knee, you tend to shut down the muscles around the knee. So they stop working as shock absorbers. So when the muscles stop working, then you tend to get much more impact, particularly walking downstairs. Steroid injection can be helpful, typically if someone has swelling or inflammation within their knee, and it's normally done within the early period. Hyaluronic acid, by these studies which I quote, has not been found to be very effective in isolation, but we tend to combine it now with steroid, and that can be a little bit more effective. And platelet-rich plasma can be effective in certain cases, typically the early arthritis cases. And then we look at surgical treatment. So that's what most people come to me for, is surgical treatment. So arthroscopic washout. So in the past, they used to call it the wash and go. You come in and get an arthroscopy, wash out some debris and go home. But we realized that that's not effective, really. It doesn't address the arthritis issue. And now we try to avoid that as best we can. We can look at arthroscopic meniscectomy, so taking away the meniscus. Now, in the setting of arthritis, if you have a meniscal tear, we wouldn't do an arthroscopic meniscectomy. But if you've very early arthritis and there's a meniscus tear which is flipped or causing mechanical symptoms, that may be appropriate, but it's done on a case-to-case basis. We also look at osteotomy, and that's where we adjust the alignment of a person's leg to offload the side of the knee that's worn, and that can be effective in some cases, but it's normally in young patients presenting with arthritis. And then joint replacement, which we'll discuss a bit further, is a very, very successful surgery in the right setting at the right time. So I'm just going to discuss some knee replacements now. So what we see here is there's various different ways to do knee replacements. What we found over the past is that we have knee replacements that we can use patient-specific implants. So we get a patient's knee and we can take a CT of that knee and use these cutting blocks to give a specific cut for that individual. Now, they've been found to be, reasonably successful, but no more successful than a high-volume surgeon doing routine knee replacement. So it's important that we don't get carried away with the fads completely. We then look at robotic surgery, and that's seen a huge resurgence, particularly in the US, and that uses what we call navigation. So we can plot that person's knee in space. We can also do a CT scan beforehand. And what it allows us to do is do very accurate cuts with this robotic arm, and it's assisted surgery. So that has been shown to be effective. But in the long-term studies, it's no more effective than someone doing an awful lot of surgery with a lot of experience. So it's important we don't get carried away too much, but there's certainly a role for robotics in knee replacement surgery. We look at all of the companies that supply our implants that we put into patients, and each of these companies has their own robotic offering. And it's important that the surgeon that you go to, that first of all, that they're an experienced surgeon is key, and whether they offer robotics or not is really incidental. I think that they want to be a high volume surgeon, which is really important. I'm going to give you a few case examples now. This is an example of what we would do when a patient comes in to see us, and we get a weight-bearing x-ray of their knees. And this is the right knee and the left knee. So here we see on the right knee that the space between the femur and the tibia is nicely preserved on the outside, but very diminished on the inside. And we see that on both sides. So this person would likely have slightly bow leg deformity. So we know they have arthritis within the region of the inside of the knee. We look at the knee from the side as well, and we see that the space between the kneecap and the front of the knee is slightly tight. So they have arthritis in not just the inside of the knee, but also under the front of the kneecap. But we always would address the patient's symptoms, where they're having pain within that, and that knee is important. We look at this person's MRI scan. We look at from the front of the knee, and we can see the presence of whiteness, which indicates fluid within the knee. But if we look in the inside here, we see whiteness within the bone, which indicates that bone is under severe stress within the knee, and that's where the site of the patient's pain is. So often x-rays are sufficient, but sometimes we have an MRI. It can be effective in terms of us looking further into the knee to get a little bit more idea of what's going on. So this person who's had that x-ray would likely have just that side of the knee replaced, and I'll show you an example of that slightly later. This is another example of a patient of mine who presents with severe pain on the outside of the knee. So slightly different configuration of what we saw, and we see that the space on the outside is largely reduced compared to the space on the inside. And the nice thing about having both knees x-rayed is that we could compare both sides. So we see the outside of the knee on the left is nicely preserved, whereas on the right it's reduced. And you see this extra bone has formed here. So this is where the arthritis exists. So in this patient, we see that they've got arthritis under the kneecap as well. So of the 3 compartments in your knee, the inside, the outside, and the front of the knee, 2 of the 3 compartments are affected. So this person is more likely to benefit from a total knee replacement as opposed to a partial knee replacement of just the affected side. So you can see this is what this lady had, and she has a nicely balanced knee, so it looks very much like the other knee. And this is the joint replacement I was using when I took these x-rays in Australia. And you can see it from the side where we've resurfaced the kneecap in addition to the total knee replacement. So this lady went on to do very well after surgery. And once again, we go back to that other x-ray of just the isolated x-ray of arthritis on the inside of the knee. And this is what we would do nowadays, is we do what we call a partial knee replacement. So we just replace the inside of the knee that's affected. So we mentioned about robotics and the role that robotics might have in joint replacement, and it's important to be aware of it. Now I'm going to show you another personal image. This is a slightly newer picture or older picture to the previous one of my immediate family, but this is my extended family. So this was taken in Tipperary in 1922. And so I have a vested interest in what the future holds, because my future probably holds a joint replacement for me. This is my grandfather here in the front, Paddy Devitt. And you notice he's wearing no shoes. So this is back in the day when they walked uphill to school both ways in no shoes, literally. And this is his brother, and these are all his brothers. So Paddy had a hip replacement. His brother had a hip replacement. This brother had a hip replacement. This brother had a hip replacement. I'm not sure about the others. I think they may have passed away before getting to that stage. But we realized there's genetics to arthritis. Now, unfortunately, we can't change our genetics. But it's important that this is probably what the future holds, that we'll be able to tell those people who are at risk of developing arthritis and maybe in some way mitigate whether the development of arthritis in those individuals. But I think the key is to maintain your body weight. And that's something that I think we all have some choice over. And I think that's really key. If we have a high risk of developing arthritis, it's important that we look after ourselves as we age. But we're not there yet and quite determine the genetics of arthritis just at this point in time. But what we do know is exercise is very important, and we're getting a lot more smart about using these smart fabrics and being able to identify which muscle groups we're weak in, etc. So the future holds an ability to look at tailor our rehabilitation to further advance our ability to postpone the inevitable joint replacement for some people, and looking how we can fully maximize rehabilitation or prehabilitation. We're about to embark on a joint lab where we look at patients with arthritis pre and post joint replacement to see if we can identify the muscle groups in which they are weak in. And I think this will make great advances in terms of how we manage patients going forward. But we use all of these smart fabrics and technologies in years to come to help us with that. People often ask us about stem cell therapy for knee arthritis, and I think it's really important because we all look for the next great panacea in terms of treating arthritis, and most people are wary, and for good reason, undergoing joint replacement because you can't go back on it. So they look for other lesser modalities. But unfortunately, the literature is just not there in terms of the use of stem cells. In fact, if you look at what the experts say, and this is taken from Australia, where I was working for 10 years, that the position statement saying that the use of stem cells is very complex, and that really we don't understand the effectiveness in arthritis just at this point. But they also say that they would currently not support the evidence to use stem cells treatment as a clinical intervention outside a clinical trial setting. So a lot of these people who peddle the use of stem cells for treating osteoarthritis are not doing it as part of a clinical trial setting. It's for monetary gain only. So it's really important just to be a little bit circumspect about those scenarios. But I think there is potential there, but we have to do it in the setting of clinical trials firstly. So I'm going to finish now with another quote from Confucius, and he said, "Choose a job you love and you will never have to work a day in your life." And we have a great job in terms of orthopedics because we give people back their mobility, we give them a new lease on life. But it's very important that you only choose to have arthritis when you've exhausted non-operative means, when you've gone through the effective non-operative measures, and then get to the point of a joint replacement, because you'll do much, much better at that point from a rehabilitation perspective. Thank you very much.
Brian, thanks for a really interesting talk. So we covered a lot in that. So we're going to start with some of these questions. So Brona's asking, do you carry out partial knee replacements, and how long do they last, and can they be renewed? And also she's asking, is it keyhole or open? So yeah.
Yes. So I do carry out partial knee replacements, and increasingly more frequently than I used to. And the reason for that is that people tend to do very well with partial knee replacements and do have a slightly quicker recovery. The prosthesis typically lasts in around 15 years or so. And what normally happens is that the other parts of the joint tend to wear out. It is a relatively easy conversion from a partial knee replacement to a total knee replacement. In terms of the recovery, patients, as I said, tend to have quite quick recovery following partial knee replacement. So they're normally walking a little bit more quickly with less pain. In terms of getting back to their normal activities, so it varies, but anywhere between, probably 3 months to up to 6 months. But in general, the partial knee replacement patients are slightly quicker than the total knee replacement patients.
Okay, good. So now someone else is asking here about knee sleeves, and are they a con, or do they provide some kind of relief for bone on bone?
Yeah, so well, knee sleeves essentially are a dressing, or a sleeve you pull over your knee, so they provide compression to your knee. So they are effective, and essentially they give a bit of feedback to your knee when you have swelling. So they don't necessarily reduce swelling per se, but they give a little bit of support to your knee. When you have bone-on-bone arthritis, they're probably less effective, and typically patients with bone-on-bone arthritis complain of a dull, aching pain in their knee. The knee sleeve might provide a little bit of support, but I don't think it's going to eradicate the pain entirely.
Yeah. Okay, good. Do you think robotic surgery is better than manual surgery, or is that the future?
Yeah, it's very interesting. It's an area which I've looked into quite a lot, and I used a lot of robotic surgery when I was working in Australia. And since I've come home, I've reverted back to manual surgery. My outcomes are just the same, and I think that robotics is likely to be the future, but we don't have any compelling evidence to suggest that the outcomes following robotic surgery is any better than surgeons who carry out high volume knee replacement. That means they do a lot of knee replacement. But I think that As we evolve and the next generation of robotic surgery comes in, I think they'll improve things, and I think we'll probably see better results with it in the future. But for now, if I were choosing a surgeon, I would choose a surgeon that does high volume, not necessarily a surgeon that does robotic surgery,
Yeah.
for having a knee replacement.
Okay, good. There's a few more questions coming in now. How do I know if I have arthritis?
Well, you have a variety of symptoms. I think you suppose you look at the age of the individual. So typically patients who are, towards their middle ages and getting more elderly are patients who are more likely to develop arthritis. It typically presents with pain. So pain at rest or pain at night is one of the hallmarks of arthritis in terms of the symptoms. You tend to have people who have decreased range of motion within their joints is another symptom. And you've also see deformity, particularly in knees, when it develops or when arthritis gets worse, but it tends to be based on symptoms. So someone who complains of pain, stiffness, and swelling within a joint.
Okay. Do you find people who have a history of like frequent road running present with knee osteoarthritis at an early age versus people who don't engage in road running?
Well, it's very interesting because I think it's a bit of a myth that running causes arthritis. And if you look at the typical body habitus of a runner, or certainly a marathon runner, they're quite skinny people normally. So they tend to have lower body weight, and therefore they're less likely to develop arthritis. But there was a really interesting study a number of years ago that I had to review, which looked at the prevalence of arthritis in a group of marathon runners and found it was actually lower than that of the normal population. So what people often blame running because they revert to running in their 40s and 50s, but they probably played more rigorous sports in their early life, and that's where they took a chunk out of their cartilage. And the running just is what caused the end result, or maybe exacerbated it. But typically, people who are active and low body weight tend to have less arthritis than people who are overweight and are more sedentary.
Okay. Actually, someone asked this here: is osteoarthritis more common in people who are obese? Is there a metabolic factor in this development?
Yeah, well, I think it's mentioned in my talk, the very simple equation in terms of how much body weight goes through your knee when you walk. So yes, obesity is a big factor, and in fact, losing weight is the best treatment, non-operative treatment for arthritis. So whether there's a metabolic factor or not, I'm not 100% sure if that's proven, but certainly weight is certainly a huge factor.
Okay, there's two questions here actually about bilateral knees. So someone's asking, can you kneel after a bilateral knee replacement?
Yeah, well, let me answer that first. Yeah, so whether it's unilateral or bilateral, you can knee after any knee replacement. It does feel a bit strange when we typically make an incision, we make it to the front of the knee, and therefore there's a slight numbness on the outside of the incision. So it feels a bit odd when you kneel down. Now, there's no reason you can't kneel on your knee, but it just feels a bit strange. Ironically, when you have bilateral knee replacements, they both feel the same. So it doesn't feel as odd. One doesn't feel different to the other. But someone gave a nice analogy. It's like wearing a pair of sandals at the start of the summer. They chafe a little bit. They feel unusual on your feet. But as your skin hardens up, you're able to manage without any problems. So there's no contraindication to kneeling after any knee replacement.
Okay. So the other question. Okay, so the other one then, someone's here asking about if you need a full knee replacement, is it better to have it sooner rather than later?
Oh, it depends on how bad your symptoms are. And we often have people coming in and saying, oh, I'm better having it when I'm young than waiting till I'm old and I'll be easier to recover. But you need a knee replacement when you need it. And I don't want to be facetious, but when you start having pain at night, when you've pain at rest, when it affects your quality of life, and I say to patients, if it's the last thing you think about before you go to bed, if you can't sleep at night, and it's the first thing you think about in the morning because you have pain in your joint, you probably need a joint replacement. So I think based on that, that's really my answer to that question.
Okay. Talking about the bilateral, then someone's just saying, can you just speak about the option of getting them both done at the same time regarding recovery?
Yeah.
I think it's a recovery time.
Obviously, we're very selective about the patients we choose to do bilateral knee replacements on. So they have to have, evidence of pain within and arthritis within both joints, and typically they're as bad as each other. The advantages to having them both done are you reduce your rehabilitation time and you're up and running straight away and you don't have to go back and have the second one done. But the disadvantages of it, it's a bit of a bigger undertaking. And as I joke with the patients, you don't have a good leg to stand on. So it can be a little bit more challenging in the early period of rehabilitation. The risks are slightly higher, but they're not significantly higher nowadays, because we have refined our surgery and it's a fairly quick operation. So doing them both together is under the same anesthesia. So really it's on a case by case basis, but patients who have profound arthritis and have really decreased range of motion tend to do very well when they have bilateral knee replacements done because they can move both legs the same.
Okay. Someone here is saying that they've had 2 arthroscopies done, but their knee is still really sore and uncomfortable. When they twist, their knee hurts, and they're just kind of wondering, I think, where should they go next?
Yeah, so it obviously depends on what age the patient is and what was the indication for the arthroscopy. But, we often find people who have had a meniscectomy or had some of the soft tissue cartilage removed from their knee. And if they've done it twice, they would suggest that they've had, some ongoing issues with that knee. What typically happens in those situations is the cartilage, the hard cartilage of the knee tends to wear out. And really, in those situations, we'd investigate with weight-bearing X-rays or potentially an MRI to see if the joint has worn out. If the patient is young and it's a relatively isolated to one joint, they may be a candidate for a partial knee replacement, but it's done on an assessment of where the pain is in particular.
Yeah, okay, thank you. Few more questions here. Someone had a triple tibioplastic fracture 2016 with plates and screws and osteotomy later on. They're still in a lot of pain. They're asking what could they have instead of a joint replacement? They do still exercise, they walk, they do Pilates. Is there an alternative, I suppose, at this stage?
Yeah, so I think with any individual like that, you can get post-traumatic arthritis, and that unfortunately afflicts younger people a lot of the time.
Yeah.
So we would always be loath to go to a knee replacement unless we absolutely had to. The same principles applied as I mentioned in my talk. Looking at maximizing non-operative measures such as body weight, occasion anti-inflammatory medication, maintaining the strength of the knee is really important. If they're not settling with oral anti-inflammatory medication, one could consider an injection of local anesthetic and steroid, or maybe hyaluronic acid can be effective in some cases. If it is a traumatic case with metalwork in place and they're heading for a knee replacement, sometimes even just removing the metalwork can improve some of their symptoms, and that would be necessary before a joint replacement, and indeed advisable before a joint replacement. So that might be a temporizing measure to help the person along the way, but we try to do everything to delay a knee replacement typically.
Okay, thank you. Someone's just asked about sports. Are there any sports not recommended post partial or a total knee replacement, example tennis or skiing?
Well, those 2 examples are good because we don't really there's no contraindication to playing those sports. I suppose if you look at kind of sports that put a high level of load through your knees, such as running or running marathons, you wouldn't really advise that, to be honest with you, after a total knee replacement, and potentially even after a partial knee replacement. But we're very nowadays we're less strict about what we would consider contraindications for people to participate in. When I was living and working in Australia, lots of patients came in, wanted to surf, and it's a fairly rigorous sport if you get very low. So I'd say if they're able to surf, no problem in doing that. But obviously everything comes with risks, but we let people participate in sports. It's good for them.
Okay, and I think it's probably the last question. Is a knee replacement always successful?
No, it's not. And I think that's where we are very particular in terms of choosing patients that were at the right time for a knee replacement. And I think one of the important things we spend a long time talking to people about is informed consent. And as part of informed consent, we have to explain the alternative options. And I've mentioned them in my talk, but also the risks related to surgery, which is really important. So I'd explain to patients that one of the things we're paranoid about is infection, and infection occurs in less than 1% of patients, but we try to do everything we can to avoid that. The other thing which people complain of after knee replacements is stiffness, and we find that patients have to really engage in the rehabilitation. If they don't get engaged, or they have too much pain and they can't engage, then they do become stiff, and that can be a pretty miserable experience for the patient. So we try to do everything we can to mitigate the risk of complications, but unfortunately they do occur. But when they do occur, we tend to treat them very aggressively and very early.
Okay, Brian, thanks very much for joining us
Thanks very
tonight.
much, Fiona.
And just so people are aware, these talks will be on the website under events as well, if you want to go back or point anyone that way at all. And there are other talks on there on skiing and golf and tennis, etc., which may be helpful to you. So our next speaker tonight is Mr. Gavin McHugh, and he will join us after his presentation, and he's going to talk about the hip replacement.
Good evening, ladies and gentlemen, and thank you very much for joining us, myself and Brian, for a little symposium from the UPMC SSC on, and this evening I'm going to be talking on common problems around the hip. So, as is customary in sort of PowerPoint talks, first of all, I'd just like to outline the learning objectives of this evening's talk. And this is something that really turns me off when I hear a talk, and I always find it's like a comedian giving the punchline to their joke at the very start. So in actual fact, I wish life was that simple and we could just go through in a sort of very systematic way of how things present and how we treat them. But that's not the way medicine works, in fact. And that's not the way that any of you sitting at home will have developed a problem and the reason you're probably listening this evening, all right? And in fact, I'm actually going to completely turn that on its head. And what I'm going to do is just present a few cases, and they're a little bit cliched, the cases, but just, and please don't anyone take offense from anything I've said, in that it's just the way I see people present on numerous occasions, and there are certain patterns in this, and a lot have common features. And I suppose the trick will be to see if you can spot yourself as one of them, or a relative, or a close friend, because often these things present in quite insidious manners. So the first patient I'm going to present is the classic, from the hip point of view, is the classic denial patient. And this is this, and the word stoic comes to mind, in that it's generally someone who just gets on with things, and they're often the last person themselves that actually to notice that there's a problem. So everyone else in the family has noticed that this person has been on a downhill spiral, maybe even over the last 2 or 3 years. They're slower getting around the place. They're often grumpy because they're not sleeping at nighttime due to pain, and they're considerably immobile. And it's that sort of like, and it is the classic with a hip in many ways, in that because it often presents in such a slow, sort of as an insidious manner, it just creeps up on patients. And what I often describe it as a farmer in their sort of mid-60s is the classic stereotype, but not often by any means, and a lot of people can surprise you. And if they actually come to the consultation with their partner, usually I look across, and to every answer that they've said they're not too bad, the partner is rolling their eyes up towards the ceiling. So this patient tends to present with a lot of stiffness. They've trouble with things like they're getting their shoes and socks early on. They might have trouble, again, if they are farming or something like that, over things like uneven ground. Their walking distance can be really reduced as well, but they just sort of knuckle down and get on with it. Sometimes there are people who really just don't like taking painkillers. Sometimes there are people who have been absolutely living off painkillers or anti-inflammatories for the last couple of years just to get through the day. And as I say, they may not have even been able to put on their shoes and socks for the last couple of years. So that I just described as the classic denial patient. And as I say, they'll often just say, I'm not that bad overall, all right? And in general, they're walking with a really obvious limp, but they're masking things quite well. Their x-rays will generally show that they have advanced arthritis. And really, when it comes to having something done, unfortunately, it is a little bit of a no-brainer in terms of progressing with a hip replacement. But as I say, talking them into going ahead can be half the battle sometimes. Again, usually with the help of family members. So that's the first patient. The second patient that I'd like to present is the sort of the super grand type of character who And patients say, you know, my mum, she's 85. She's last year she was out running around the shops, no problem, and suddenly she's just really, really slowed up in the last little while. And the reason I present it in that often it's sort of put down to things like just getting older, and I really hate this phrase, and that someone's just deconditioned because they're getting older, when generally they just have a worn hip and it's a pure mechanical issue that is actually slowing them down. And sometimes patients will turn around and say to me, you know, am I not too old to have my hip replaced? And I'm like, well, no, quite the opposite. You're too old not to have it replaced, in that the last thing you need is as we get older and our strength starts to reduce anyway, is to have an extra noose around your neck in the form of a worn and painful hip. Quite often I'll suggest to patients that they do actually go ahead of the hip, and that represents their best opportunity or chance of getting back to normality afterwards. And this can be strange in that, as opposed to the sort of insidious decline in the last patient, quite often this can sort of like deteriorate quite quickly. And as I say, literally they can say, yeah, 3 months ago I was able to do this and I no longer can. I can now hardly get to put on the kettle in the kitchen to make a cup of tea. As I say, you're in terms of your mobility, you'll often jump down a level of mobility very, very quickly with any deterioration, in that someone who is completely independent will go down to one stick. Someone who is with one stick will go down to then a crutch or even two crutches. And then, as you see there, onto the walking frame. So in many ways, the more we can intervene to correct a mechanical issue, the more we can keep people independent for longer. And certainly I'm very much off the belief that, assuming from a medical point of view, it is possible that hip replacement is not what it was like years and years ago in terms of what it tends to involve with the risk and recovery process. Yes, the risks are still there, but they're considerably lower than they were many years ago when blood loss was considerably more throughout the surgery. The third patient then I'll present is the 40-something weekend warrior, all right? And this is someone who used to play a lot of sports type of thing, and so they may have played a lot of GA growing up, or soccer. Now they play 5-a-side 2 or 3 times a week, and it again just tends to come on. They may have been aware of the hip or niggle in their groin for quite a while. Sometimes they've been getting treated for a groin strain type of issue for the last year or so, and it's slowly starting to creep in with them, and they're finding it more and more difficult to go ahead with their say, for example, the indoor or 5-a-side or set, whatever it is that they enjoy doing. Again, it could be multiple different sports. They can progress quite slowly, and oftentimes they'll appear going with a problem, but not in bits. So they're still able to sort of go ahead with their normal day-to-day activities, but more sporting things are becoming that bit more difficult. And this is something that represents a bit of a dilemma, because often they have a significant amount of arthritis in their hip, and ultimately the only option for them is going to be a hip replacement. But it is a real one to weigh up. So as opposed to the first two cases, this is really, really one where you got to have a sit down and a chat with regarding the risks and benefits of going ahead, and whether or not the hip replacement. And there's another patient coming up shortly where you have to sit down and go, you know, is a hip replacement going to live up to your expectations and what you want? And quite often these patients actually can be happy enough knowing that what the problem is, knowing how to handle it, and if that means taking an anti-inflammatory twice a week before they play their indoor soccer, they can manage pretty well. Now, things in due course will deteriorate with time, but as I often say, there's a time and a place for everything, and just sort of jumping into a hip replacement is often not ideal in this type of patient cohort. And it can occasionally be worthwhile trying an image-guided injection into the hip joint itself. And again, I'll speak about that with one of the other cases. But sometimes what I'll often do with patients like this is, and it sounds kind of strange, but I say to them, listen, the option is a hip replacement. You come back when you're ready. And the question they ask then is well, how will I know when I'm ready? And it's one of those strange things. And I say, you'll just know. You'll know when you're ready to go ahead. And sure enough, they come through the door 2 years later, maybe go, yeah, you're right, I'm ready. And sometimes what has triggered that, maybe waking them up from sleep at nighttime. That's often the trigger. They may have noticed more and more difficulties with their normal day-to-day activities that they hadn't had before. So even potentially getting through the day in work is more of a struggle. Again, things like even getting into a car can be sort of, require a maneuver, as can putting on their shoes and socks type of thing. And that's often just, these are the type of triggers that they go, yeah, it's time to have something done with it. The next patient then I'll present is, and of course this is topical at the moment with the documentary Netflix and Painkiller, and must admit it was pretty mesmerizing. But I call this the sort of the cliff edge type of patient. So this is the patient who really, really suddenly deteriorates, and I'm talking going from being essentially normal to be almost like a broken leg type of discomfort. So, and this can happen overnight. It could be after even a minor twist or something just strange. And when you often quiz these patients, they may have been aware of a little bit of stiffness in the hip or the occasional little bit of difficulty with stiffness after sitting, something like that there. But all of a sudden deteriorate really, really rapidly to the point that they may come in on 2 crutches. And often from a mechanical point of view, what sometimes just happened is that a part of the cartilage that was worn has just flaked off, or they've just hit a real raw spot, sometimes the bone beneath has collapsed a little bit, and it has just generated a huge degree of inflammation and severe pain. So, and it's unfortunate in that these are the type of patients that really can't wait a huge length of time in order to be seen. It's kind of cruel to see the degree of pain that they can come in with, and often, whilst it seems like an aggressive sort of act, often just going ahead as soon as possible with a hip replacement is the way to treat these. And as I say, it almost is akin to a broken leg type, in terms of discomfort that they'll present with. The next one we'll call the double nappy. So this is the patient who either has a history themselves of issues with their hip as a child. So, and again, they've often been, as I told, they had a click in their hip, or maybe their mum said that they had to put on double nappies for a few months when they're younger. Occasionally, they've actually been under the pediatric service and had procedures done on the hip to try and, so essentially they were born with either a slightly shallow socket or indeed the hip completely out of joint, and the procedures would have been to try to put the hip back in the socket essentially and keep it there with time. And these are often hips that have functioned really, really well for a number of years. But as I often say, in terms of, if you think of the sort of like from an analogy with regards to cars, well, obviously, you weren't kind of given the Mercedes type of hip, if that makes sense, in that if their hip is a little bit shallower, it's going to wear out at a certain stage. Some of these patients may have had a little limp, especially with sort of more and more demanding activities, but oftentimes they've been completely normal. And the problem is that they do deteriorate early, and that's when I say they weren't quite given the Mercedes of hips. And oftentimes these people can be in their late 20s, early 30s. And this is the patient who can say, but why me? Why have I now got arthritis in my hip? And as I say, it is, again, like a lot of things in this business, it is a purely mechanical issue, in that because the socket is that bit shallower, it's going to wear with time, and it leads to development of premature arthritis in many ways, and no different from all the other patients. In general, the treatment, whilst we try and sort of prolong things for as long as reasonably possible, the ultimate treatment for these patients is going to be hip replacement. Once again, the odd one of these can sort of get some improvement with an image-guided injection, again with a course of physiotherapy to strengthen up their glutes and muscles in general around the area can help improve things. With regards to the physiotherapy in terms of the hip specifically, I have no problem with lots of strengthening activities. In general, I'll often say to avoid lots of stretching activities, and I find, if anything, lots of stretches specifically around the hip tend to actually aggravate the hip and make it worse. And not frequently I'll see someone who's actually been through a rehab that seems to have made things worse, and often that's the reason. They just need to pull back a bit from their stretching, and they can get longer out of the hip essentially before they progress to having a replacement. The next patient is the sort of typical 50-ish-year-old female who either attends lots of reformer Pilates or yoga classes and has started to notice some pain in their groin area. They may have noticed that some of the exercises, either in yoga or Pilates, that one leg is a bit different than the other, right? But often they don't have an awful lot of symptoms at this stage, other than when they're doing their classes such. And this is often the patient where their x-rays aren't that warm, but they are getting some degree of pain from inflammation around the hip. And it is one, and quite often they come in expecting a hip replacement as such, in that they common things are common, and they're there saying, well, I think this is, I'm now ready. And this is the patient, again, when it comes to sort of talking over the pros and cons of anything. I'm a firm believer in, if your range of movement in your hip is almost normal, then a hip replacement, well, it's not going to make the movement an awful lot better. And in fact, the opposite, the movement in that joint afterwards can actually provoke some ongoing discomfort in and around it. It's very easy to irritate a lot of the muscles that work around the hip joint, and you can be left somewhat underwhelmed with the result of a hip replacement in this cohort of patients. I would certainly recommend exhausting conservative measures by that. I mean, sort of, again, an image-guided injection or two in and around the area, and quite often they will actually get improvement with this, and by quite a bit of time before progressing to hip replacement. Again, the common theme of this talk, you'll see, is sort of it's injection versus hip replacement. Why is that? Well, keyhole surgery in the hip has a sort of a very limited set of indications, and in general, these are younger patients with what we call labral tears, which are the cartilage tears around the hip. And in general, if someone comes in and sees me in their 40s, 50s, 60s with hip pain, like, in general, there is no option for something like keyhole surgery on the hip. So we are left with do nothing, try an injection, conserve anti-inflammatories, versus something like a hip replacement. And obviously it's a jump up to a hip replacement. And again, these are the type of patients that need to be kind of very, very strong in that, are we going to go ahead or not? The next one patient is the sort of high level endurance athlete. And this is, you can just see there, they may not be an ultra marathon runner, but they love running their 10Ks regularly. They may have done Dublin Marathon, a competitive time last year. And they're the people who are left really, really disappointed to find out that they have arthritis in their hip. And again, it's quite strange in that it could have been developing for several years, but because they're fit and active, they weren't really very much aware of it. And as I say, they're quite disappointed to learn that they have proper, well-established arthritis in their hip, and that ultimately, again, all I can offer is a hip replacement. It's interesting that while some surgeons do allow their patients back running, I tend to say that in general, from a mechanical point of view, it doesn't make a lot of sense to me doing a lot of running afterwards. I'd look at a hip replacement as an opportunity, absolutely, to get back to the vast majority of activities that you enjoy doing. And if that's indoor soccer, tennis, squash, all of these activities, absolutely fine. 5-a-side. Skiing, I have no problems with. If you're the type of person who runs, 10K 5 times a week, I think from a mechanical point of view, it is likely to catch up with that hip and cause premature failure of the hip. And I think getting more focused with things like either swimming or cycling and will actually buy them a lot more time with their hip either replaced or not. But again, it's the type of patient who is really quite disappointed to learn that in due course that their only option is going to be a hip replacement. And these are patients, as we know, as we sort of, I think as the generations go in, we're pushing boundaries more and more. And these are often, I often see people who are extremely fit in their, not only even 40, 50, 60s, even into their 70s. I remember one gentleman who had done the Marathon des Sables the year before, and he was in his early 70s. And it's a lot of these activities are incredibly demanding on your body. And whether we like it or not, as we get older in age, our collagen is changing. And as our collagen changes, it makes us more and more prone to developing injuries. Sometimes these are in forms of tendon injuries and frank tears. Sometimes they're just pain and discomfort in tendons. Sometimes they're actually joints starting to give way, be they any weight-bearing joint, be they the hip, knee, or ankle. And as I say, it can be, again, frustrating for people to know that, unfortunately, whilst their mind is fully focused, that they have a joint that is letting themselves down. The next patient I'll mention then is my sort of cliche, sort of tends to be much more common. Females around about the age of 50 who enjoys walking, and a lot of middle-aged females enjoy walking, and it's great, and it comes with so many additional benefits. But and quite often these people are often either just perimenopausal or postmenopausal, and it's a particular, I suppose, in some ways, something that I see quite frequently, in that they come with they presume that they think their hip is worn, and in actual fact, their hip is absolutely fine. And where they're sore or painful is over the outside of the hip itself. So just to the side of their buttock, essentially, they can't lie on that side. It's incredibly sore. So to even press the bony prominence over the side. And as I say, this is completely unrelated to the hip joint itself, which usually presents with pain in the groin area, and that the pain is on the outside, but can be extremely severe as well and really stop people in their tracks. So this, and as I mentioned, in terms of tendon, this is where your gluteal tendons insert into the tip of the greater trochanter, and unfortunately they're put under a lot of demand when we're walking. The insertion becomes either inflamed or just mildly sort of degenerative, and I'll often describe it a little bit like a frayed rope in terms of how it's presenting and giving symptoms. So these are the patients who, not needing a hip replacement, need a course of physiotherapy, need and potentially can get relief with a steroid injection over the area, and quite often it'll take a second or even third injection to settle this down. Sometimes people's their own GP will be able to give this. Sports medicine will often do a lot of these as well, and I'll see some myself. But it's just to know that potentially it's not the actual hip that's the cause of the problem. Extremely common. In one clinic last week, I must have seen 12 people in a row with a similar problem, and it just seems to come in waves, potentially around this time of year as well, or people are trying to get more and more walking over the summer, and it's only after a couple of months that it really starts to limit them in their tracks. And on one hand, whilst I think the exercise is really, really good and comes, as I say, with multiple benefits, not just from a musculoskeletal point of view. it is activity related, and sometimes it does mean sort of pulling back on the walking a bit. In general, stopping the activities isn't going to work, in that if you, with these degenerative type condition, if you stop the activity, as soon as you start back again a few weeks later, it'll come back with a vengeance. So you have to try and sort of limit your activities, and, as I say, strengthen the area up with some physiotherapy, the injection, and which I'll often suggest a talk with our GP in terms of on the assumption that they are sort of perimenopause, that things like the formulations of HRT that are available now can make a considerable difference. And I think it is important in that there is no doubt that estrogen plays a very important role. Obviously, it's well beyond the remit of my level of expertise, but as I say, it's just something that I see really quite frequently. So, as I say, I hope you found the last few patients just a little bit interesting, and hopefully some of you recognise, as I say, yourselves or family members among the crew. It's by no means the limit of what we see in a day-to-day. It does represent the fact that these things, even though the diagnosis is quite often just arthritis, it can present in a multitude of different ways with pain, discomfort, and at the end of the day, I think it makes a lot of sense to get the vast majority of these issues addressed and treated, and to potentially prevent them getting worse with time. Thank you very much, and if we have any questions, I'll be glad to answer them.
Thank you. Hi, Gavin. Welcome. Now, Gavin's joining us from his car. If you want to look flashing lights, sorry, he's actually on his way to a hip meeting in Cork. So thanks for joining us, Gavin.
Thank you, Fiona.
That's okay. So we're going to have some talks. First one from Declan's question is, how do you know when you need a hip replacement, particularly if you're not in a lot of pain?
Yeah, in general, I would say if you're not in a lot of pain, you probably don't need a hip replacement just yet. Particularly if you're younger, I would say it is a case of getting a bit more out of it. I spoke about the sort of the disability aspect of things as well, and I am conscious sometimes in younger people that a lot of stiffness can really cause trouble and catch up. So, but again, I suppose that's where the consultation comes in, where seeing someone and seeing how they act and behave and how it is interfering with things helps make the decision. I suppose in many ways is the number one question to ask yourself: is it impacting on me on a daily basis? And that could be in your work, in your leisure, or whatever, and significantly hindering it. And that's the ultimate question to ask, and that determines whether or not you not need it as such, but would benefit from it.
Okay, thank you. Someone, Cassie, said, can you go kayaking after a hip replacement?
And my general answer to everything is yes, right? The only thing I'm not sure I did allude to in the talk, but the longer distance running, I recommend you stay away from. But anything else, and now the kayaking specifically probably cause quite a degree of hip flexion. But these precautions we put in place for the first few weeks until everything heals up. After that, I ideally want someone to have as close to a normal hip as they possibly can. So I'm happy with whatever. Right? Years ago, the risk of a hip dislocating or popping out of the socket was considerably higher when we use a lot, not to get too technical, but we use a lot smaller of a head than we tend to now. So, and most females now use a 32 mil head as opposed, and males would be a 36 millimeter head. So if you imagine, it has to jump the radius in order to get out. Whereas years ago, the head was only 22 millimeters. It was much smaller. So it should enable people to enjoy a lot more activities as such.
Okay, good. Someone else has asked something similar, and I'm not sure about Nordic walking. Do you know what Nordic walking is?
Nordic walking in terms of the poles and stuff. Yeah, I think so. Yeah, absolutely. So we actively give people the Nordic walking poles, usually a couple of weeks post-op. So now that's just to get the walking style. The Nordic style is actually really beneficial after hip in terms of getting you upright and getting the weight going through the hip and getting a sort of a normal gait pattern as such without limp. So I would nearly actively encourage it. Yeah.
Okay. So if someone's they're saying if they had a first injection, first of all, for the pain relief, and it's only lasting for about 72 hours, is it worth trying a second one?
Probably not is the answer, right? And injections in a hip can be a little bit hit and miss. They do seem to sort of work a lot better and more reliably, essentially, in knees. But I do think there is, if you get it early in the hip, there is a real role for it. And some people can get lucky and get 8-9 months out of a single injection. So but 2 or 3 days. I mean, it's not going to do any harm. Is it going to help more? Possibly not. I don't think that's unusual. It just depends on how badly worn it is.
Yeah. One was asking about perceived satisfaction rates. Are they generally higher for the hip than the knee?
In general, I would say yes, but I often describe that a hip's own worst enemy is itself, and that the general consensus among the public is that hips are fantastic and easy and have no problems, and that knees aren't nearly as good and that the outcomes aren't as good. So I think people automatically come in with lower expectations with knees, and a lot of the happiest people you'll see are people that have had their knees replaced and they go, it was a complete game changer. Now, on a similar level of hip, but if someone comes in with a little bit of discomfort in the hip, either over the side, which I spoke about, that trochanteric pain, or an occasional pinch in their groin or something like that, they're almost, quite disappointed with it because they were expecting it to be perfect. At the end of the day, it is a replaced joint. It's generally a replaced joint that is a hell of a lot better than the one that was in. In fact, 97%, 98% of the time. And probably say, possibly half of those, maybe even more, would have a completely forgotten hip that they wouldn't even know. They'd maybe have to think which hip was replaced, But some people have just that conscious sensation that it just feels a little bit different, whether that's psychological. So people will describe, it feels like they're sitting on. You're not sitting, and you don't even sit on your hip joints. So it can like you're sitting, but it's just, I think it becomes a conscious awareness for some people that it just hasn't quite settled down.
Yeah, I think someone here is asking about, does it ever occur that a hip prosthesis can be pushed too high, where the ball might be inserted into the cup and cause pain? So I suppose that may be a perception after surgery. Yeah,
exactly. So it feels like that. So the ball is in the socket, right? So it cannot, it should not move within the socket as such, all right, bar a millimeter or two, right? But just a normal walking, it is articulating in and against the socket. Now, anything can happen. There's the socket as well. The socket can migrate up within the bone that it's fixed in, right? But it's extremely unlikely. Other things can happen, but rarely actually nowadays with hips. Thankfully, they rarely move once they're in.
Yeah.
We sometimes see hips that are 20, 25 years, and they start to create problems such as that, like things actively loosening or wearing away. The plastic liner can start to wear away. Again, that tends to be older hips that have been in place for years, where the plastic wasn't the same high quality that it is now. So, touch wood, we really don't see it on modern implants as of yet, anyway.
Good. Somebody is asking, and it's probably for us as well, how does one manage your schedule if you need a full hip or knee replacement? But I suppose most people will start with their GP if they haven't been to their GP, wouldn't they?
Exactly. Yeah. I mean, the most will start with a GP referral, and I think occasionally that is important as well, especially. The majority of people are going to be through their insurers, and occasionally more and more you'll find insurers asking to see the GP referral, and if there's any queries and anything, it's just like one little obstacle that they like putting in the way. So, and I think ideally it is absolutely attend your GP anyway, but it's just I think it can keep things safer for them in the long run as well.
Yeah, and look, and also there is a number there on the ask a question, or also to get in contact with the GP liaison. She'll also help you with talking through referrals as well. And Gavin, I think your own secretary numbers are up there as well, so they need to do that. Can you distinguish between tendinopathy in a hip and a mechanical hip problem?
In general, well, yes and no. Sometimes it can be difficult. In general, the tendinopathy that I spoke about over the side is excruciatingly sore to touch just over the bony prominence of the side of the hip. So usually that's it. So sometimes patients that have labral tears can refer the pain out over that side of the hip. So occasionally it can be tricky, but you know, an MRI or an MR arthrogram, which is an MRI scan with some dye injected into the joint, can help sort of delineate that. But a lot of it is just in the history itself of where the problem is, how it's aggravated, you know, for example.
Yeah. Someone's just asking about the bilateral, and I suppose that maybe asked about what's the recovery like to have a bilateral hip?
Sorry, I was just swiping away messages.
Okay.
So in general, I'm going to use my normal analogies here that you'll love, Fiona. But the problem with a bilateral in the first day or two is you're almost like a tortoise in its back. All right, because the single hardest thing getting out of bed, all right? So you have to actually start off with the hardest activity, all right? Normally, if you've one side done, you can use the other leg to kind of push yourself out a little bit, but with both done, it's that little bit more difficult. Once you get over that, right, and this is where people, it takes a huge sort of leap of faith. After the first day and a half to 2 days, right, it is like the two hips just recover at the same pace. And I often say to people, listen, when one hip is 4 weeks old, the other is 4 weeks old. They genuinely commit. And I touch patients coming back at 6 to 8 weeks post-op. There really is no difference in the bilaterals to the ones that have had one side.
Yeah.
And they walk in every bit as well. In fact, sometimes they're even better off. Same with the bilateral knees, and it's something, again, like from my point of view, I mean, not to sound so, there is actually no sort of motive behind me to doing all the two together, other than, as I say, I've seen it work, and I've seen it work so often, and I think it really is an opportunity for patients sometimes to get things fixed rather than sort of push it out for another 6 months, another year, and so on, you know.
So someone did ask that, but what he's asking about is why he says he wants to have a full knee replacement, and has also been told he needs a hip replacement. How does one get around that?
I mean, in general, if it's on the same side, in general, the consensus would be that you start with the hip on above, because a hip will occasionally refer the pain to the knee, but a knee won't refer to the hip. So we tend to start with the hip above. Now, I have done, on occasion, I have actually done the hip and knee together at the same sitting. It's a little bit more unusual than, say, both hips together and both knees. But again, it just depends on the patient. And I don't mean to be, but in terms of what they're actually up for, what I think they're able for as well. And that's it, right? Okay. It's certainly not. It's not that common to have a hip and knee done at the same time, but I've done, I think, 3 or 4 or 5 times that sort of number.
Okay, so I've just got one question here that someone has asked about the cross-border, because just the cross-border isn't back at the moment. So if I get Rebecca, again, the GP liaison will get in touch with prices if you're interested, and we'll just email you there as well. Do you need a referral from your doctor for the cross-border? Not really, or from the north, we don't. If you give one of us a call, we'll go through it isn't the cross-border at the moment, but we can still go through the process and the prices with you. And if anyone there is from Northern Ireland, I am up there all Monday and Tuesday. It's on the website. I'm going to do various talks in Omagh, in Newry, Belfast, Armagh, and in Ballymena. So if you're in any of those areas and you want to come along, I am talking about all surgery at SSC now that the cross-border is gone. So listen, thanks so much for joining us tonight. We will be sending a survey out. And remember, these talks are available on the website in the next few days. Thank you.